Hello, my name's Dr. Will Evans. I'm a general practitioner in Leeds in the United Kingdom and an academic at the University of Nottingham. Today, I'm delighted to have with me Professor Régis Peford de la Tour, who's a professor of haematology at the Haematology and Bone Transplant Centre at St. Louis Hospital in Paris, France. And also, I'm delighted to have with us Jess Ratcliffe, who's a patient living with PNH. In this section, we will cover the topic recognizing and referring patients with PNH. So to start, Régis, perhaps you could give me a little bit of an overview of paroxysmal nocturnal haemoglobinuria.
Yes, thank you very much, and hi everybody. So basically, PNH is a rare chronic acquired blood disease. This is not the cancer, as the prevalence is about 1 to 2 patients per million individual worldwide. It's an acquired mutations which is occurring in a gene that is called PIG-A, and that is acquiring in hematopoietic stem cells. So basically, this gene is responsible for the synthesis of complement inhibitors that are placed at the cell surface. And of course, if there is these troubles, then your cells are not able to inhibit the complement, which is constitutively and always activate throughout our life, protecting us against infection. And if you cannot inhibit, then the complement is destroying your cells, coming to what we call hemolysis for red cells, and all those destructions are also associated with clots, which is outstandingly severe for PNH patients because this is associated often with death. The other thing that we have to know about this disease is that she's not appearing in everybody. You have to have an acquired bone marrow failure disorder behind, which comes to the triad, hemolysis, thrombosis, and bone marrow failure. So all patients are not presenting the cells, they're all unique. And the presentation basically is on two sides. You have some patients who are mainly presenting with bone marrow failure. It's about 2/3 of the patients, and the treatment will be the treatment of aplastic anemia. And on the other side, you have the patients who are presenting mainly with hemolysis, needing some complement inhibition. And this is mainly about those patients that we're going to speak today. In the middle, you have some patients that you cannot classify that are in the middle and will go to one side to another during their life.
Thank you, Régis. That's fascinating that there's such a variability within such a rare disease as well. Jess, as a person who lived with PNH, I'm interested to hear, how did you initially present?
That's a good question. And I don't know exactly, because a lot of the time, actually this right now is the first time that I'm learning fully about the depths of PNH. But my initial diagnosis was sort of pinpointing towards initially an iron deficiency, but also there was a bone marrow biopsy as well, which was possibly the most painful thing I've experienced to date. So I feel there was that exploration on both sides. But from my understanding, within the PNH that I have, I'm less likely on like the blood clot side. So I feel like it's possibly pointing towards the hemolysis side. But for me, it was all down to having a sore throat that just wouldn't shift. And so I think that also then ties to the compromised immune system and actually being on antibiotics and then penicillin that wouldn't tackle it. And that kind of was the starting pull of the thread to discover ultimately that I had PNH once it was something that was tested for.
Okay, yeah. Thanks, Jess. So obviously there's significant variation in how they present. So I think kind of thinking as a GP, as a primary care practitioner, are there any key symptoms, Professor de la Tour, that we as primary care practitioners should be looking out for?
Yes, that's a very good question. And that's something we are always exchanging with GPs, because most of the time when the patient they're coming to them, they are not doing the diagnosis straightforward because this is not specific symptoms. This is very hard. And when it came to the discussion of the diagnosis and when they got diagnosed, then they culpabilize, saying, wow, should I have think about this before? I mean, just to give a general overview, A GP will see 1 to 2 PNH in an entire professional life. So this is extremely rare. So I would say that some things that are really typical, it's the outstanding abdominal pain with nothing behind. You don't have any inflammation or abnormalities through ecography or scanner. The exams are quite normal, but the pain is outstandingly high. That's possibly something related to PNH. Thrombosis, of course, especially in young patients, when you don't have any cancer or predisposition that might explain this. Dark urine is also something that is could evolve the diagnosis. But the other symptoms, usually nausea, fatigue, small pains, all those things are not typical. So I would say yes, the abdominal pain, the dark urines, and patients who are constantly recurring this kind of signs might be something you are thinking about. And obviously, if you have abnormalities on the CBCs, especially hemolytic anemias with those clinical signs, of course, it makes you more easy to think about.
Yeah, no, that's great. So I think, you've touched there on one of my questions. Obviously, as you say, patients present with potentially quite variable clinical features. Are there other tests that you would recommend doing in primary care?
Yeah, basically, I would say that an acute abdominal pain in such a patient should go to ultrasound to eliminate thrombosis. For GPs who are diagnosing PNH, or for GPs who are following patients with PNH, this is really the fear that we have. So any sign that makes you think about a thrombosis, you should go to ultrasound scanner very easily with those patients, because it is something that we are all keeping in mind. For the rest, I guess that a well-done CBCs looking for hemolysis is enough. And then we go for the diagnosis, and this is very cheap. It's a flow cytometry. We are not screening genes because there is no genetic recurrence in this disease. It can be mutations, it can be deletions, it can be many genetic abnormalities. So we are just looking for those inhibitors at the cell surface, and especially on white cells, because the red cells, as I told you before, can be destroyed. So you can miss the diagnosis if you're looking on red cells. Just the flow cytometry in white cells, namely neutrophils and monocytes. This is very easy to do. This is cheap, and you can have the diagnosis in one day. And all hematological centers, even in the city, a common lab can do it. So flow cytometry is the main diagnostic tool that will say to you if your patient has PNH or no.
That's great. Thank you, Reggie. It certainly highlights to me that, that's a very interesting about the abdominal pain and some of these non-specific symptoms, looking for the hemolysis, and then moving on to, as you say, a readily available test in hematological centres. There is, like many rare diseases, a significant diagnostic delay. Jess, in your experience, did you identify kind of potentially missed opportunities for diagnosis?
It's a good question. I think so, because it was almost over time, and it was about sort of a 12-month journey from initial investigation to diagnosis of PNH. I think there was a lot of the symptoms that I now know to be signals of PNH that were happening on their own. And I never, as a patient, I never connected them together to say, go to my GP and identify that I was feeling really fatigued or that I was having sort of a bit of a brain fog time. Because I think unless you know how you should be feeling, you don't always know when you're not quite feeling 100%, especially being the age that I was when I was diagnosed, which was 25. I don't think I would have experienced fatigue as I know it now and been able to sort of say, this is something I'm experiencing, and attach it with, say, something else that maybe then would point to PNH. But really trying with an initial signal to kind of look for the others, which for me, I don't feel that was really done until the latter part of my diagnosis journey, sort of more towards actually testing my blood for certain signals of PNH, which is what led to the diagnosis. It all felt a little bit kind of sporadic, looking for different things rather than looking at it perhaps as like the full picture. But then I think because it is so rare and not something that is immediately tested for, that in itself is quite hard to kind of fit those two together. So rather than testing everybody if they show signs of fatigue, more often than not, that fatigue probably won't be a signal of PNH. But in some of those cases, it will be. And so for me, it was almost how can you look for the signals as a whole, even in somebody that might not sort of be the kind of classic patient of PNH, which at the time I was sort of told that I wasn't at the age that I was.
Yeah, no, absolutely, Jess. And yeah, thank you. That's a really, really powerful to hear your own personal story of this. I think, so a take home from me would be that, when there is clinical suspicion, and as you say, it can present with a range of different clinical features and can be quite non-specific, but to work down that path, and when you notice a hemolytic anemia, and potentially look for that in a broader range of patients, then onward referral to hematology and then a readily available test of flow cytometry is key for establishing the diagnosis. So I'd like to just take this opportunity to thank you both, Jess and Regis, for a really fascinating conversation. Thank you very much. Bye-bye.
Thank you.
Thank you. Take care.
Hello, my name is Dr. Will Evans. I'm a general practitioner in Leeds in the United Kingdom and an academic at the University of Nottingham. Today, I'm delighted to be joined by Professor Regis Peford de la Tour, who's a professor of haematology at the Haematology and Bone Transplant Department at St. Louis Hospital in Paris, France. Together, we'll be discussing the subject managing patients with complement inhibitors. So, Regis, perhaps to start, it might be useful to find out when patients with PNH should be treated with complement inhibitors.
Yes, thank you. Well, I think it's very important because we might overtreat some patients. So basically, a treatment should be given if the patients have some clinical signs related to the disease. This is very important because you don't want to treat biology. So basically, what we learn is that a PNH is an hemolytic disease. Then this disease is going to give some symptoms or clinical signs related with this intravascular hemolysis, namely fatigue, abdominal pain, dark urines. So this is the first, I would say, indication for complement inhibition, clinical signs related to intravascular hemolysis. The second situation, you may give some complement inhibitors in those patients in when they are transfused in red blood cells because of hemolysis. So in other words, when the level of hemolysis is very high, and then you need transfusion to get rid of it, or at least to support the hematopoiesis of the patient, this is another situation where complement inhibitors are indicated. And finally, the last one is thrombosis occurrence. We know that thrombosis is related to death in this disease, and when a patient is experiencing these complications, he must be treated with complement inhibitors. We will avoid recurrence and save life. So, three situations. First one, clinical symptoms related to intravascular hemolysis. Second one, transfusions need in red blood cells. And the third one, thrombosis occurrence.
Great, thank you. That's very clear. So I understand there's a number of approved complement inhibitors. Perhaps you could sort of talk generally about how they're given and how they work, their mechanism of action.
Yeah. So the first one that has been developed in 2005 to 7 was eculizumab. This drug has been a revolution in the field. It's a humanized immunoglobulin that is targeted C5. I told you that PNH is related to an impossibility for patients to inhibit complement. So we are bringing complement inhibitors to support this deficiency and to help patients not to destroy their cells. Eculizumab is an IV injection every 2 weeks, blocking the complement at the terminal pathway, at the C5 level, and it's a drug that is given IV, well tolerated, and that is able to inhibit the hemolysis related to this complement inhibition. This drug has been worldwide available, save life, protect against thrombosis occurrence, and again, was drastically improving life of the patient. However, the main problem with this drug was those 26 injections a year. Patients should be injected every 2 weeks. So at that time was developed was in 2015 approximately ravulizumab, that is exactly the same drug, exactly the same target. There is just some amino acids change, only 4, that increase lifelong treatment, and they may be injected every 2 months. But the clinical effect is exactly the same. Recently, we find out that some patients were suboptimal responders to those C5 terminal inhibition. Suboptimal responders may be about the clinical signs with some symptoms remaining, or even some patients that are still transfused. And they are still transfused because there is a low-grade extravascular hemolysis under anti-C5. So hemolysis is not occurring in the blood anymore, but in the tissue. And this extravascular hemolysis might be detrimental in some of our patients. And for those patients, we decided to block proximally the complement. And that's where the pegcetacoplan was developed. It's a C3 inhibitor, so it's at the early phase of complement activation. And this is allowing to block intravascular hemolysis and extravascular hemolysis. And this drug is also given subcutaneously 3 times a week, which is also something that is important for patients, because as you may imagine, they are gaining in terms of autonomy, being able to self-treat them.
Yeah, no, absolutely. I imagine that must be a huge change for patients, so that the disease can be not taking over every fortnight, needing an intravenous infusion. Yeah, thank you for that incredibly clear answer. That makes it a lot clearer to me, certainly. Perhaps one thing that would be useful, because if you talked about the extravascular hemolysis, so how does that manifest in patients?
So the extravascular hemolysis is not the clinical symptoms. Basically, what the patients are suffering for is anemia. The hemoglobin level is not coming back to normal, and they are still very regenerative. In other words, retics counts are outstandingly high, more than 100 giga per liter. And the bilirubin also is a bit high, but LDH are still normal. So when you have those kind of patients receiving terminal complement inhibition, namely C5 inhibition, namely eculizumab and now ravulizumab, you may identify those patients with extravascular hemolysis by CBCs and blood analysis, looking for high retics, anemia, and high bilirubin level. This is highlighting that there is a remaining extravascular hemolysis, since LDH are normal, and LDH, as you know, are illustrated in intravascular hemolysis. And for those patients in particular, proximal blockage with pegcetacoplan or others that are under development might be very important and might really improve their quality of life.
Great. Yeah, no, thank you for that. Are there other things that if we have patients on these treatments, we should be looking out for, and what monitoring we should do?
Yes, thank you, Will, for these important questions. As you may imagine, if we are blocking the complement, we are exposing our patients to the risk of infectious disease. So that's the reason why vaccination is outstandingly important, especially for C5 inhibition, but also for C3. So for distal terminal complement inhibition, we are recommending meningococci vaccines, but also in some part of the world, antibioprophylaxis, to be sure the patient is protected against this infection. For the proximal blockage, it's even higher as a security and risk prevention. we are recommending not only meningococcal infections, but also pneumococcal infections, Haemophilus influenzae vaccinations, because those patients, since they are blocked proximally, they are not able to opsonize anymore. So they are exposed to higher risk, theoretical higher risk of infections, because for the moment, in the studies that has been published, it has not been the case. But we really need to be careful. And the other thing that we have to keep in mind is that those proximal blockers, for the moment, has a very short term in terms of development. We have very few data on long term. So we might also see in long term some other complication, theoretically, of course, but that's the reason why we have to be very careful. Cancer or autoimmune disorders, I mean, other situation where we do know complement might be important in opsonization for the eliminations of immune complexes, for example, very important too.
So obviously we've talked about the substantial benefits patients have experienced from these complement inhibitors, some of the limitations and some of the side effects. Just kind of looking forwards, what drugs are in development for PNH that may help address some of these limitations?
So I will say that this part is the most enthusiastic part in the field. And as you may see, and the chance we have for patients, that there is, as I'm always kidding, as much drugs than patients. Basically, many drugs are in development. First of all, biosimilars are coming, which is an outstanding news, because then you know that those treatments are expensive. And if we are going them to be cheaper, it will be probably help the healthcare for many patients, especially in low-income countries. So we have at the moment ABP 959 that is coming, that should give exactly the same results than eculizumab, but being definitely cheaper than eculizumab. Then we have other drugs that are in development, mainly sub-Q, targeting C5, so still terminal complement inhibition, like crovalimab. We have also pozelimab that is developed. I think we won't expect much more than eculizumab or ravulizumab. But again, developing other routes of injection is important, and sub-Q is one of importance. And finally, but really last but not least, is the proximal inhibition. You see that the pegcetacoplan was outstandingly helpful, giving rise to normal hemoglobin level in patients who are suboptimal responders under terminal complement C5 inhibition. We have other drugs in development. We have danicopan that is targeting factor D. We have iptacopan that are targeting factor B. So those drugs are really targeting, like pegcetacoplan, at the proximal level. And the other thing that is outstandingly important for those drugs is that they are oral drugs. So we are coming from a disease that was devastating 20 years ago, killing many young people. The overall survival was about 22 million times, means that when you are diagnosed at 30 years of age, you might have 50% of your patients dying at 50. Now, to a disease that might be controlled in the coming years with just a pill in the morning, and that's it. Because as you can see, we are coming from a devastating disease, that a disease that will be controlled in the next 5 years, I think, or so, by just a pill every day.
Thank you. I mean, that is such exciting news, and I think the treatment landscape for PNH is almost an exemplar of rare disease and how things can move forward so far, and we can change a devastating disease. It's incredibly exciting. So I'd like to take this opportunity, Professor de la Tour, to thank you for giving a really clear oversight of the treatment landscape. I think you've painted a really nice picture of both the disease and how these drugs interact with that complement and how it inhibits that complement pathway. So I'd like just to take that final opportunity to thank you once again for informing us all. Thank you.
Thank you, Will. Hello, my name is Professor Régis Peffaut de la Tour. I'm the head of the French Reference Center for Plastic Anemia and PNH in Saint-Louis Hospital in Paris, France. Today, I'm delighted to welcome Jess Ratcliffe, that is a person living with PNH, and we will address and discuss the patient journey in PNH. So Jess, please, could you just recall for us your personal experience of living with PNH?
Yes, absolutely. So I was diagnosed with PNH back in 2016 when I was 25, about to turn 26. So it felt quite young. And really for me, my sort of outstanding memory of it is that it just came out of nowhere. It was very much unexpected. It felt like a sort of lightning bolt out of the blue. And it all started because about 12 to sort of 18 months prior, I'd had a sore throat coming back from holiday, thought it was very normal, thought it would all just sort of happen because I'd been on the plane and maybe fallen asleep. And, you know, the aircon on the plane sort of gives you a dry throat sometimes. But when coming back, I realized that the sore throat wasn't shifting, it wasn't going away. So I went to the GP and was put onto antibiotics first of all. That didn't do anything. And then it was penicillin. And that didn't do anything, which ultimately led to the curiosity as to why. And so, long story short, that sent me to my local haematologist at the Royal Surrey, so in Guildford, to run some tests. And at first, the tests were sort of pointing towards low iron levels. And so I was given an infusion of what I remember, and I think this is accurate, at least this is sort of what I remember, this big bag of iron that was sort of referred to as 5 years worth of iron. And I swiftly got rid of that out of my system, which is what ultimately led to more curiosity and more wondering what was going on. Alongside this as well, I was actually in the process of moving to San Francisco for work. And so it was all a little bit rushed to kind of see whether we could crack it before I moved, and it was delaying my move a little bit. And so I was given that iron before moving. 2 months later, came back for my birthday and had already got rid of that iron, which has sort of led to the next tests. And then it was bone marrow biopsy, more blood tests, more curiosity. And then it actually ended up being that following Christmas when I came back for a visit from San Francisco that the diagnosis was discovered that it was PNH. And again, something I had never heard of. Because it was over Christmas, I was actually diagnosed over the phone and had to try and write that big, long paroxysmal nocturnal haemoglobinuria on a little Post-it before then Googling what on earth this thing was and really starting that journey to understand how it was going to impact my life and potentially change my life, with a lot of questions about what that might look like, especially at the age of 25.
Yes, thank you very much, Jess. I think what is outstandingly important in your history, obviously, is the time that takes to do a diagnosis of a rare disease, the feeling that you have to feel alone with MDs, but also in family, because of course this is extremely anxious, being not recognized and not knowing the disease. Do you mind just to recall this situation and how long did it take to make the diagnosis in the end?
I would say it probably was around the 12-month mark to go from actually sort of digging in deeper to what they thought was low iron levels. And at times as well, there was like, maybe this is low B12. And I think particularly being a young woman at that time, like it kind of, well, hopefully still am, but youngish, but younger at that time, anemia and low iron is quite common. So I think it was very much pointed towards that because it wasn't immediately tested for because PNH is so rare. And I just remember that sort of length of time from, especially being away in the States, that initial iron infusion, which would have been in like the February before I moved, to then actually being diagnosed in the January of 2016. So about that 12-month mark.
Yeah, this is what we are also experiencing in France. We appreciated this time being about 1 year now, which is outstandingly long when you're living with a disease that nobody knows that you have. And again, I mean, it's not to culpabilize our colleagues. I mean, it's a rare disease. It's difficult to think about, but it's just highlighting how important it is to really disseminate the main clinical signs that should make you think about PNH and to refer you to a hematologist. So then, were you treated and what kind of treatment did you get?
Yes, so I initially was put onto a fortnightly drug. And then I always struggle to pronounce these, but I'm going to go for it. Eculizumab was the first one. And that was, first of all, I had an infusion here in the UK, but because I was still living in the States, I actually went out and started treatment long-term over there. So I remember, because again, this was the scary part with that 12 months, I was flying back and forth to the States because I was working in San Francisco, but we had a London office here. And one of the big things that I learned about PNH is the risk of blood clots, and long haul flights are obviously not super friendly to that risk. But getting out to the States, I got on the plane and had this also like big bag of blood thinning needles. So that was also quite an experience, trying to get on a flight with all of this stuff that you're not typically allowed to take on flights. And I was on the fortnightly drug for about just over a year again, until I actually moved back home in 2017 and was very lucky to then join a clinical trial, which ultimately was working on the drug that is now every 2 months rather than every 2 weeks, which in itself is just such a game changer for both sort of how you think about PNH and being somebody with PNH. I went from having to get this drug every other week and it being very much on my mind all the time to now every 2 months. I feel there's almost this little bit in between where I actually forget that I've got PNH, which feels like a real luxury. And so that's the drug that I'm on now.
Yeah, I think your experience is very important and very updated, because you could benefit from clinical trials to increase this time between 2 injections. Could you please go back to this change when you were treated? In other words, when you got this eculizumab treatment, did you feel better? And on another point, was this, and you told us, logistically difficult, but with this organization, did you feel only logistical problems, or there was still some medical problems going in, fatigue or pain or whatever? Could you just elaborate on this, please?
Yes, absolutely. I remember getting that first drug and just feeling such a difference. I think I hadn't realized how fatigued I was because I'd been so used to like operating at that level, not knowing that I should really be feeling any different. And I remember I would just put it down to the fact that when I was working in London, and San Francisco changed this a little bit because my commute went from being like an hour and a half there and an hour and a half back to being like a 15-minute walk in the sunshine. So that was quite helpful and a difference in terms of the energy levels. But my big memory was really that as soon as I received that first infusion, that first drug, it was just such a shift in almost like clarity of mind. It really got rid of the brain fog that I'd been feeling and hadn't been able to pinpoint why I'd been feeling it or how long for, but also just my energy. It really felt like it conquered the fatigue that I'd been feeling that, again, I'd sort of become used to. But it was only when receiving that drug that I realized, oh, like this is how I should be feeling. This is the sort of energy I should be having. And the only sort of dip I would feel leading up to my next infusion, and I still feel it now actually, I have my next infusion on Monday. So I'm in the week leading up to it. And I always, leading up to my treatment, will feel that dip. And it's a real sense of, again, like brain fog, fatigue. And when it was a fortnightly drug, I'd feel that maybe 3 or so days leading up to it. But when it's the 2 monthly drug that I'm on now, I typically feel it a week or so into receiving the drug itself. And then I always sort of refer to it as my superwoman juice, because as soon as I get it, I then feel back to normal and I feel like a sort of recharged Duracell bunny. But in that dip before, you really start to realize when the fatigue and brain fog takes hold that you do have this thing, and the drug kind of corrects me.
Thank you, because it's really illustrating very well the progress from no treatment then to eculizumab every 2 weeks and now ravulizumab every 2 months. Basically, the last question I have for you is what we could do more in the future, how we could improve more your quality of life. What do you like more to be treated with? In other words, what is your best and ideal future for you now?
Good question. I think the first thing that comes to mind is really somehow being able to not have this week where there is the dip, and almost whether that is simply shifting the cadence of treatment from the 8 weeks to maybe 7 weeks, just to miss that dip in fatigue, like that in itself would be quite a game changer to me, because I wouldn't then have to be adapting what I do and sort of what I have energy for, I guess, in that week leading up to the treatment. That's the sort of number one thing. And then honestly, nothing else immediately springs to mind, because I feel very lucky to even have treatment for this. I think because it is so rare, and PNH is so, incredibly, sort of, there's only a few of us really that have it. I feel incredibly lucky that the drug has even progressed from the fortnightly to the 2 monthly in itself. Like if I was still on the 2 weekly or the fortnightly drug, it just would feel still very on my mind all the time. You're always thinking about, okay, I can't do that on that day because I've got this. It's very close. Whereas with 2 months, it feels it gives you a bit more space to actually live as if you don't have PNH. And so the number one thing, if I kind of could crack anything or hope for anything, would be that it would reduce that dip where I actually feel the brain fog and the fatigue. Because then if I wasn't to experience that, I almost wouldn't feel like I have PNH at all, other than having to get the treatment every so often.
Well, thank you very much. I think that your history is illustrating very well the medical progress from a disease that was devastating, with thrombosis events and high risk of death, from a disease that we have an injection every 2 months. You also illustrated very well that we need to continue the progress in medicine and to try to find some treatment that are more efficient, more convenient. But anyway, thanks a lot. I was very pleased to discuss with you today. And yes, congratulations.
Thank you. Thank you very much.